Good afternoon, everyone. Welcome to Yashoda Hospitals webinar series. Like what we have seen last time, it was very interactive sessions. Most of you are asked most of the questions. Let's keep this session also more interactive. And this is going to be 15 to 20 minutes quick webinar. Today, we have taken a very important topic for today's session webinar, post-operative nursing management. As we all know, for any clinical outcome and best surgical outcome, surgeons put a lot of efforts in the surgery to make it a perfect surgery. Even though it is critically important is how post-op management, how nurses are giving the care for that patient. So complete is a teamwork. That's how like the amount of effort surgeons are putting in the OT, same you have to put critically into the post-op care area. So we decided this topic to put into discussion. So we are covering most of the topics in the today's session is what is post-operative care, post-op nursing check, FOLEY'S catheter, central lines, ICD and epidural catheter. So today we have expert panelist. We are managed to get him on the board today because he is very busy in his schedule. I would like to introduce Dr. K.C. Mishra. He is an expert panelist. He is consultant intensivist and HOD Department of Critical Care. He is having vast experience, more than 2 decades in critical care area. Today's speaker, Ms. Hema Bindu. She is a program coordinator and nursing education, having vast experience into the clinical teaching as well as education department. Hema Bindu, please take over and start the webinar.
Thank you, sir. Good evening, everyone. As you all know about the topic, today we are going to discuss about post-operative management. Mainly here in this topic, we are going to discuss about care of catheters and drains in post-operative nursing management. So let's start our topic. Yeah, firstly, here in this topic, we are going to discuss about what is post-operative management.
Share the presentation.
Yeah. Now, is it visible?
Yes, it's visible. Continue.
Thank you. So here today, we are going to know about what is post-operative care and its phases. Then the important thing about post-operative nursing checks. And our main topic is about care of catheters and drains. Here, I'm going to discuss about peripheral catheters, central and arterial catheters, FOLEY'S catheter, epidural catheter, and patient on ICD. So to know about post-operative care, it will begin when we receive a patient from OT till the discharge from PACU unit, post-anesthetic care unit. So here in the post-operative care, we are having 3 phases. Phase 1 indicates immediate or post-anesthetic care where intensive nursing care is important. In phase 2, it is immediate phase where we are encouraging the patient to do the self-care. And the last stage is about we are preparing the patient for the discharge and it will last for 1 to 4 days. The important thing, when we receive a patient from the OT, first we have to take the patient handover, then only we have to move on to the case sheet handover. So in our important nursing checks, we need to assess the level of consciousness of the patient. We have to monitor vital signs and provide any pain management. So first thing is we have to assess the pain level of the patient based upon the score. If the patient is on unconscious state where he cannot answer anything, we have to use a behavioral pain scale. Then the important thing in all the patients, what we need to take care is ABC checks, airway, breathing, and circulation. So airway, look into the oral cavity, any secretions, go for the suctioning. And when it comes to the breathing, you have to assess the breathing pattern and auscultation method. And also you have to provide an oxygen supplementation if required. And here the important thing is whenever you're providing an oxygen supplementation, we have to provide humidified oxygen as the patient is in dehydrated stage to prevent the irritation of the pharyngeal muscles. And the next thing is fluid therapy, antibiotic prophylaxis. Yeah, when it comes to the antibiotic prophylaxis, 1 hour prior to surgery, we will provide. So if required, mainly in case of any longer surgeries, they will go for a second dose or else we have to stop it. Then fluid therapy. When it comes to the fluid therapy, we have to maintain the fluid and electrolyte balances as the patients will be on NBM and also due to blood loss, there may be a chance the patient may land up in dehydration state. So to maintain that, we have to maintain the fluid and electrolyte balances. Then prevention of DVT. So as the patient will be in immobilization state, we have to provide an activity, or else we have to go for the DVT stockings. And after the surgery, 8 hours, we can go for the early ambulation. But based upon the surgery, we have to decide whether immediate ambulation is required or not. Then the important thing next comes glycemic control. So same as where the patient will be on NBM, blood loss, the patient may land up in hypoglycemic state. So we have to check and we have to maintain their glucose levels. The next is intake. How much ever we are providing the treatment, but intake, nutrition support is also important to decrease the hospital stay. So go for it. And the important thing, when the patient is undergoing any abdominal surgeries, for sure we'll go for the NG tube feeding. So provide continuously. Then drains and mobilization. So whenever you're receiving in a patient, regarding the catheters and drains, the important point is we have to check for the labeling, whether the proper labeling has been done or not, and the dressing site. So mobilization, it's based upon the surgery, we have to go ahead. So now comes our main topic, care of catheters and drains, where we are going to discuss about peripheral line, central lines, and arterial line, FOLEY'S catheter, epidural catheter, and drains. So first, peripheral cannula. So when the patient with a peripheral cannula, we have to check whether the site is in patency or not. And whenever you're assessing the site, you assess the site based upon the VIP score. And to administer the medication, follow the protocol of SASH, saline, administration of drug, and saline. So as already we had done with the topic, you can go through our webinar to have any in detail of peripheral cannulation. So let's move on to central line. So here, whenever you're receiving a patient with a central line, you need to consider 4 important parameters. First thing is care of catheter, the next medication administration, blood sampling, and CVP monitoring. So based upon the CLAPSI bundle, we have to take care of the central line catheters. So whenever you're assessing the site, check for any discolorations. And if you notice any soiling of the dressing, you have to change it immediately, or else it will last for 7 days. Then if you want to administer any medications, first thing, clean the hub, then check for backflow, then followed by SASH method. Same thing, saline, administration of medication, then saline. Then the important thing, you want to go for any blood sampling. So when you want to collect any blood sampling from the central line, so important thing is first hub cleaning, then you have to withdraw 5 ml of blood where you are going to discard it. We are not going to send it for the sampling. Then the next, take another syringe, collect the sample, how much ever it is required. Then you have to send it for the investigation. Then again, you have to give a flush, then clean the hub with an alcoholic swab. The important thing, you should not maintain the port with a blood stain. Clean it thoroughly with an alcoholic swab. So this protocol we need to follow whenever you're collecting a blood sampling. So here, I'm having a query now. So already you are giving in potassium correction for the patient, and the doctor has been advised you to collect a potassium sample. So what you'll do now? Yeah, I'll expect the answers in the chat. You can drop your answers. I repeat the question again. Already you're giving in a correction, potassium correction for the patient, and the doctor advised as in a regular sample, taken a potassium sample. So what you'll do now? Will you collect the sample from the same port, or else will you wait? Yeah, so the first important thing is whenever, even though the patient is on central line, so if you want to collect the sample, you have to prefer on to the other hand. So other peripheral areas, you can collect the sample. If in case, onto the other hand, if the patient is having AV fistula, you cannot prick onto the site. Then what we need to do? Stop the infusion for 15 to 20 minutes, then you can collect the sample. That is how you can do. So remember, whenever you're going, any medications or any fluids going onto the particular hand, we should not collect any samples. You have to prefer the opposite hand, or else we have to stop the infusions and wait for 15 to 20 minutes, then you can collect the sample. So this we have to follow. And you can have a look onto the CLAPSI bundle. So where you have to follow the same thing. And the important thing, whenever any inotropes are going onto the particular line, you should not give any flush. And we have single line medication administration like TPN or as inotropes. From that port, you should not administer any other drugs. So remember it. Then next comes our arterial line. Here also the same protocol for the care and also for the blood sampling. So here we need to think about the pressure band. So where we are maintaining in a 300 mm of Hg, why we are maintaining that? Why we need to maintain 300 mm of Hg of pressure when the patient is on arterial line? Is it really required? Yes, may I know the answer? Yes, we have to maintain. It will counterattack the arterial line pressure. So for that, to prevent the clotting and the backflow of blood, we are maintaining pressure bag with 300 mm of Hg pressure. So here, as a nurse, we have to remember about zeroing of the arterial line. So here we are having a video where you can see very clearly. So first thing is, you have to off onto the patient side, open the hub, clean the side, then go for the zeroing in the monitor. You need to wait until the waveforms will be straight and till you notice 0 by 0. Then come on to the patient side again, onto the patient side, then recap it. So then you will get a value. This is how you are going to do the zeroing. So now my question, how oftenly we need to go for the zeroing of the arterial line? So shift-wise we will do it, or else you need to wait. So how oftenly we need to do arterial line zeroing? So here, the important thing. So whenever you're noticing a sudden drop or sudden increase in the blood pressure values, or else any disturbances you are noticing in the waveform, we need to go for the arterial line zeroing. So that you all need to remember. So here in the arterial line, the important caution you should remember is you should never inject any medications through the arterial line. So this is an important thing that we need to remember. If suppose, if you are administered any drug through the arterial line, please don't hide. Immediately escalate to the doctors so that we can prevent the complications. Yeah, the next one is FOLEY'S catheter. So when the patient is on FOLEY'S catheter, as a nurse, what we supposed to do? So what care we need to take and how we need to place the bag? So first thing is same. As for central line, we need to follow the CLAPSI bundle, and here for the FOLEY'S catheter, we have a COTI bundle. Accordingly, we have to take care of the patients. So first thing is closed drainage system and the securing of the catheter. So we have to secure the catheter onto the lower aspect, inner aspect of the thigh. Then we need to make sure it should be below the waist level and it should not touch the ground. So other thing is, whenever you want to collect any sample from the FOLEY'S catheter, what we need to do? First thing is you have to clamp the catheter, wait for 20 minutes, then move on to the patient side. From the Y junction, you have to clean the site, and from the balloon pump, from the urinary drainage port, we have to collect the sample by using the syringe and needle technique. So you have to aspirate the urine. So remember, from urinary drainage port, we have to collect the sample. Don't go for the Y junction. Why? Because there may be a chance we can aspirate the distilled water instead of urine. So at the urinary drainage port, you have to collect the sample. So that important thing you all need to remember. And other thing, whenever the ward boys or IMS are coming to drain out the urine from the urinary bag, just guide them. For single patient, only one check, they have to go discard, clean the check, and they have to go for the another patient. They should not carry the same check for all the patients. So that you have to inform and educate our IMS or ward boys. So that's about the FOLEY'S catheter. So here, regarding the FOLEY'S catheter, a question again. So how we are going to inflate the balloon of the FOLEY'S catheter? By using distilled water or by using normal saline? What we need to use? May I know the answer? Okay, so we have to prefer distilled water rather than normal saline. Why? Because the normal saline will cause any crystals in the balloon port and it will block the balloon port. So that's the reason we should not prefer normal saline. Instead, we have to use distilled water to inflate the balloon. So here, when the patient is on FOLEY'S catheter, mainly in the post-operative patients, we have to observe and where you are going to maintain the IO chart. So in that, whenever you're noticing the urine output is less than 20 ml per kg per hour, immediately inform the doctor. And other thing, you need to observe for the color, like any hematuria, presence of RBC in the urine if you are observing, or is any cloudiness in the tube which indicates a pulse. So immediately inform the doctor. So next about epidural catheters. So epidural catheters mainly we will use for anesthesia administration or else for analgesic administration. So whenever the patient is on epidural catheter, so here on the image you can have a look where on the back where you'll have a complete adhesive tape. So you have to check for the dressing or else any oozing for the side. And the important thing, as we are introducing into the epidural space where there may be a chance of CSF leakage. So you have to check for CSF leakage before administering any medication and assess the patient for any numbness in the lower limbs and monitor blood pressure. As we are attaching the adhesive tape, there may be a chance of formation of any blisters. So look for that. So that is the main thing about epidural catheters. So focus onto the CSF leakage and assess for the numbness and the blood pressures. So these things, please remember when the patient is on epidural catheter. And the last, it's all about ICD. So when the patient is on ICD, so what are the important things as a nurse, what we need to remember? So first thing is positioning of the patient. And then we have to check the column movements in the ICD bag. If the column movements are present, then it indicates it is in position. So we have to assess that. So before, whenever you're offering a ICD bag to the tube, make sure the ICD bag we need to fill with 100 ml of NS. Without that, you should not connect. If you're connecting that you failed to remember about 100 ml of NS in the ICD bag and directly you had connected to the tubings. What may happen with the patient? The patient may land up in emphysema. So please be very careful. 100 ml of NS is mandatory before connecting. And whenever the patient is going for any ambulation or during transportation of the patient, you should not clamp the ICD bag. So the main thing we have to remember is as Foley's catheter below the bladder level, in the same way, ICD bags you have to maintain below the chest level. So that we have to remember. So whenever you're emptying the bag, so you have to empty the bag at that particular moment, clamp the catheter, double clamp to be done, then only how to empty the drain. So again, before reconnecting, fill the bag with 100 ml of NS, then connect, then unclamp the tubings. So this you all need to remember. So whenever you're going to document about the ICD drain, so you need to do minus 100. Why? Because that 100 is our normal saline. So these are the important points we have to remember regarding this. So when we need to inform the doctor, first thing you'll be assessing the amount of drain. So here, if you are noticing in 1 hour, it is more than 5 milliliters per kg, then you have to intimate. Or else consistently for 3 hours, if you are noticing it is more than 3 milliliters per kg, then also you need to inform the doctor immediately. So here you can look that we are having different types of drains. ICD, intercostal drainage mainly we will use for pneumothorax and hemothorax, whereas for major surgeries we'll go for hemovac drains, and for minor surgeries we'll go for Jackson Pratt. So when the patient is having any drain, so we have to look for this. You can just have a look over here. So whatever suction is required, then emptying the drain, then we have to assess as a nurse, as we are staying with the patient for 24/7, we are the one who need to inform the doctor whether it to be removed or not. So check it, and if the drain levels are minimal, then inform the doctor so that they will go for the removal of the drains. So that's all about our topic. Is it clear? So then if you're having any queries, you can ask, or else I'll go for the questions. Shall I go for the questions now? Yeah. So our first question. So where we need to secure the Foley's catheter? Inner aspect of the thigh, outer aspect of the thigh, or else on both the sides? Where we need to secure the Foley's catheter? You can drop your answers in your chat box. Okay. So it is inner aspect of our thigh. Yeah. The next question. How long can epidural can be left in? Epidural catheters. So till how many hours we can place the epidural catheter in place? Any guesses? As I didn't discuss about this, so any guess from your end? You can try. Only for 24 hours, 72 hours, or else 24 to 48 hours. Sorry, 24 to 72 hours. Yeah. So it's C. So mostly after 48 hours, they'll be removing the epidural catheter. If not, 24 to 72 hours is acceptable. Then our last question. So whenever a nurse is shifting a patient with ICD from ER to ICU, clamping ICD is the best nursing action. So are you going to strongly agree or disagree the statement? Yes, strongly disagree. Thank you.
Excellent, Hemabindu. You given excellent presentation today, and you try to make it very simple way. So, audience, we can just put us the questions right now, or you have any doubts later. Also, you can put offline. We are there to answer your questions 24 hours. So, would like to request our expert panelist, Dr. K.C. Mishra sir, to overview on the how important is nursing management in post-operative care, and just give the importance of it.
Yeah, thank you, Dr. Amar, and good afternoon, everyone. I always believe nurses are the backbone for any hospital to stand, or any, if you believe that one hospital is doing good job, then nurses has to be good, and they has to be well trained, and they know what they are doing. Then only we'll see a good recovery in every field. Let it be the patient satisfaction or their recovery. So that is the first thing I want to tell, and I'm very happy to be the part of this kind of sessions where there are a lot of nurses throughout India is going to attend this session. And it's a important thing what we are discussing today regarding the post-operative care of the patients, mostly for the drain and catheters what we are discussing. And Himabandhu, she has like nicely narrated all the important points, and few things where I believe she's little wrong. I need to stress on those things. So apart from that, let's see any post-operative thing, we can like divide into the early part and late part. If you see the early part where the patient will come out of the surgery, like they must have received some form of anesthesia. Let it be a spinal anesthesia where the lower half of the body will not be working, but the patient will be conscious enough. They will not have any issues while breathing and all. These are the cases where they can have significant amount of hypotension. So these patients, you have to, in post-op ward, in the initial part, they can develop severe hypotension. So these patients need to be checked their vitals. And if the spinal, sometimes the effect may go up towards your chest, where they can have breathing difficulty also. As she told initially, like any patient post-op, in the initial part, ABCDE is very, very important. So airway, breathing and circulation that need to be checked in every case, at least in the initial part when they are coming out of your operation theater. Second thing, in general anesthesia, when most of the time we do extubate the patient before shifting to the post-op ward, or sometimes they continue ventilation for some time in the post-operative ward. So if you see in the recovery of post-op ward, if patient is being extubated, these are the people who require oxygen, and there is a probability that patient may hypoventilate because of the anesthesia effect may there for some more time. So these are the two things. So every patient post-op, initial part, ABCD is very, very important. So every patient need to be checked properly and thoroughly. So coming to the drains and catheter. So before coming to the drains and catheter, a few things like as a universal thing for every case, we need to check on this fast hug PID. So this is very, very important. Let it be a post-op case or a medical ICU or in the ward also. Most of the time in ward, patients are stable enough, so there may or may not be required. But any other case, let it be in any form of ICU or post-op care, the fast hug PID is very important. Let it be feeding. Let's say in post-op cases, most of the time we don't feed them for a day or two, but nowadays, the things are changing. We need to feed them early. Then analgesia, DVT prophylaxis is again very, very important because these people are not getting mobilized for a period of time. So in those cases, DVT prophylaxis comes handy. Most of the time, we can be able to give some anticoagulation. If at all we are not able to give an anticoagulation also, in those cases, pneumatic compression device, which are like your IPCs, intermittent pneumatic compression device, has a role in DVT prophylaxis, but mostly these TED stockings and all what we are using, they don't prevent DVT. Third thing is regarding early physiotherapy and mobilization that cannot be overlooked. Every patient post-op, let's say nowadays we are mobilizing or ambulating patients within few hours of surgery. Even ortho people, they are mobilizing patient after 2 or 3 hours of total knee replacement. So mobilization and ambulation helps the patient in recovery. Like apart from developing atelectasis, their oxygen status will improve, their pain relief will be better. All those things are important. Analgesia, again, one of the important thing in post-surgery patient. Coming to few other things, I think urine output. What Dr. Mr. Like Himobindu told is little wrong. Let's see. This concept I want to tell each and every person. Let's see, FOLEY'S catheter is there. We all are aware of your our Cotti bundle. I'm not going to go, and she has told also nicely with picture things. So the thing is regarding the urine output, when we should be concerned about the urine output. The urine output will differ as per the body weight of the person. It cannot be fixed at like 20 ml per kg per hour, what she has shown, which is a wrong one. So basically the thing has to be any patient, if the urine output is less than 0.5 ml per kg. So let's see, if somebody's weight approximately 60 kilos, if the urine output is dropping below 30 ml per kg per hour, then you should be concerned about that patient. And that is the time, in an hour or two, if the patient's urine output is dropping below 0.5 ml per hour, you need to inform the doctor. It has been mentioned like if the urine output is less than 0.5 ml per kg per hour for 6 hours, they are very prone to develop acute kidney injury. The early part, if you can recognize and do something to improve upon that, that will go a long way in patient recovery. Coming to the ICD, she asked the things where I need to stress. One, ICD, it has to be kept below the chest level. That is one very, very important thing. Second most important thing is the air vent has to be kept always open. If you're not keeping the air vent open, if you have kept a ICD for a pneumothorax patient, if the air vent is not open, the pneumothorax will persist or increase. So air vent has to be always open. Now, in my ICU, I just take that air vent so that they cannot close it only. Third thing is you have to keep water at that level what has been kept in that. So if that up to that level, it may be 100 ml or 150 ml, that level has to be maintained with water, and it has to be water sealed. So that tube which is going inside will be underwater. By that, you will not entertain air inside. Otherwise, if there is no water, the patient will develop pneumothorax. So there has to be a water seal. And for every patient who is on ICD, you should see that the ICD is patent by looking at the column movement. And regarding the, I don't know, from like all the sisters, they do a common mistake regarding the output of the ICD catheter. Let's see, when you are monitoring how much is the drain in an ICD, we always, let's see, 500 ml you detect 100 ml. Why? There is no reason to detect it. If you have seen that ICD bag, the zero starts from the mark where the water you are filling. From there, the zero mark starts. So if it is 200 ml, it is 200 ml. You don't have to deduct 100 ml. 100 ml is nothing. That is maybe a dead space where you are only filling water. The marking starts from there. So if it is 200 ml, it is 200 ml. If it is 300 ml, it is 300 ml. So don't deduct, like if you have seen 300 ml, then you deduct 100 ml and writing that the drain is 200 ml is wrong. Okay, I don't know. This is a wrong concept. Second, regarding Ryle's tube feeding or Ryle's tube. See, most of the surgical patients, I think she has not touched up on the Ryle's tube. 1 or 2, 3 things which are important. When it comes to Ryle's tube, the Ryle's tube, most of post-surgical cases, we keep Ryle's tube continuous aspiration for a period of time to see how much Ryle's tube aspiration is coming, but not in all cases, mostly for the cases who has underwent some abdominal surgery. Ryle's tube aspiration need to be monitored, how much is coming. If it is significant, then or if bloody or if bloody secretions are coming or altered, like let's see black color RT aspiration is coming, then also we need to inform the doctor as early as possible regarding the feeding and aspiration. Ryle's tube aspiration, if you are not having a continuous aspiration, no need to aspirate Ryle's tube. And feeding, again Ryle's tube feeding. Better to go for a continuous feeding when the patient is in ICU or sick enough with a feeding pump than a intermittent or bolus feeding. Glycemic control is again very, very important when it comes to patients who are in post-operative, because if the sugars are not well controlled, their healing will be poor and they may develop secondary infections. I think rest of the things, Hemobindhu was touched nicely and told properly, so I don't want to touch upon. So I'll be looking forward for the questions. Thank you.
Thank you, sir. It was very practical way you just covered an important topic. So let's take, Pratusha, any questions are there? We'll discuss these available.
Yes, sir. Sir, there is a question. What is the importance of nutrition in the post-operative patients? And how would, about the TPN, and they are asking about this. What is the importance of TPN in the patients? What is the importance of post-surgical patients with TPN?
Yeah, I'll just cover both, not only TPN, ventral feeding also.
Yeah.
You see, the basic problem in our ICUs, in my ICU, we have done a study. So we have seen around like consecutive for 2 months, how many people in our ICU are malnourished or they are at the risk of malnourishment. So it is coming to almost 80%. And my ICU is a medical ICU where we have different form of patients. So if in my ICU it is 80%, maybe we can generalize to any other ICU in India. In India, we cannot compare the people who are the guidelines which are there from the Western country, where maybe the malnourishment rate is very less. In India, most of the people, let's say 80% of people are at risk of malnourishment. So in those cases, to delaying feeding is wrong. Okay, that is one part. Second part is, let's see, there are some myths. Post surgery, you might have seen most of the surgeons, they don't start feeding till they see a bowel sound. That is wrong. There is no reason to check bowel sound to start feeding. Even if the bowel sounds are not there and you have done a surgery where you have not operated on the bowels, you can start even within 4 to 6 hours of post-surgical time feeding. That is enteral feeding, I'm telling, right? ICU feeding. If you have handled the bowel, maybe little more, 8 to 12 hours. If the surgeon is confident enough that the bowel repair, whatever they have done is good enough, they can start feeding early. Let's see, because of some reason you are not able to feed enterally to your patient. Enteral is always preferable over parenteral nutrition. Maybe patient is having vomiting or chances of aspiration is very high. Once you started feeding, patient had significant blotting and pain abdomen and all. In those cases, maybe in very few cases, or patient is having GI bleed or there is an obstruction. In those cases only we can't give enteral feeding. May not be that much important when it comes to post-surgical cases. In those cases, you can think of TPN, but TPN should not be started early because TPN itself has its own complications, like it increases chances of infection, it increases chances of hyperglycemia and re-feeding syndrome, one of the most dreaded complications of feeding those patients early. So if at all you want to give TPN, better to start little late, maybe after 3-4 days in Indian scenario where most of the patients are malnourished. But as per guideline, you can still wait up to 7 days to start total parenteral nutrition. Whenever we are starting total parenteral nutrition, better to start with all bags, like different bags will be there, no? Where you will have carbohydrate, protein and lipid, all will be mixed and given. Or sometimes supplemental parenteral nutrition. What is supplemental parenteral nutrition? We give enteral nutrition, but we are not able to reach the required calorie for your patient, maybe over a period of 4 or 7 days. Patient is very sick enough where we are not able to feed them adequately. In those cases, we give supplemental parenteral nutrition. Apart from the enteral nutrition, whatever we are giving, let's say 30-40 ml per hour, there we add a supplemental parenteral nutrition in the form of, let's say, sometimes we give only proteins like amino bottles will be coming, or sometimes we give only protein lipids like small lipids are coming, or sometimes we give less amount of covering all the component of your carbohydrate, protein and lipids. But this is how it has to be. Every patient, we need to think about feeding them enterally and maybe start with a lower diet and better to go with continuous feeds than your intermittent or bolus feeds. If at all you are not able to feed them for a period of time and the patient is malnourished, then you can think of starting TPN. Usually better to start little late than early.
Great. Excellent, sir. So there is a question on if there is an accidental removal of epidural once the patient has shifted from the post-surgical unit and to the ward. So what is the immediate management by a ward nurse that she can do?
See, first of all, epidural catheters, because it is only secured with plasters, there is no stitch or something we take. So if the epidural catheter is removed, the most important thing what the nurse need to see is it that the whole thing came out or a small piece of epidural catheter is left behind? To know that, if any nurse, it is very easy to find out the tip of the epidural catheter will be color coded. Let's say this is the epidural catheter, the tip will be color coded, usually blue. So if you can see that tip, the color coded tip, that means the whole epidural catheter has come out. If let's say because of breakage or something, small portion of epidural catheter is left behind, that becomes a big nuisance because that itself will cause infection at the later date that requires surgical removal. So first of all, if epidural catheter has come out, just see that the whole epidural catheter is out or not by looking at the tip, which is color coded, usually blue. That is the first thing. Second thing, nothing more need to be done. Just keep a plaster, fix it. Then you have to change the mode of analgesia what you are giving. Mostly this epidural catheter we use for analgesia only. Once the epidural catheter is out, nothing to worry about. If the whole catheter is out, just inform the doctor and you need to change the mode of analgesia from epidural to some other form of analgesia. Let it be a paracetamol based or some opioid based or sometime NSAIDs.
So you mean to say like we need to just keep a pressure dressing and then we have to plaster it till the
That's what. The most important thing here is to make sure that the whole epidural catheter is come out. If then it is broke and a small piece is left behind, that is a big problem because they need to be removed surgically. If the whole catheter is out, nothing much to worry. You just apply occlusive dressing and change your like analgesia what you are giving from epidural to some other form.
So there is one more question. What would be the normal drain per hour in the intercostal drains?
So there is nothing called normal drain. See why you have kept a ICD. So there may be many reasons why you are keeping an ICD. For a let's say a pneumothorax patient, there only air is leaking. There you may not have much of drain only. There the air only will be leaking. There is no fluid collection. Let's say a pleural effusion patient. Pleural effusion, when you calculate pleural effusion around 1,000 liter or 1 liter or something, that 1 liter will come out. After that, the drain may come down significantly. But in few cases, it may continue. Let's say severely patient is having hypoproteinemia. They can have 100 to 200 ml per day, maybe 400, 500 ml initially. But you cannot generalize like how much the ICD drain will be for any patient. The only worrisome thing what we need to know about ICD drain is, let's say you have kept a drain, ICD drain for a hemothorax. Hemothorax means we are draining blood. In that case, the drain amount makes very much sense. Let's see, in an hour, if it is more than 250 ml, Hemobindu has told, if it is more than 5 ml per kg, so it comes roughly around 250 ml. If 250 ml of blood is coming, which is looking after the first drain, let's see, initially some collected blood will come out. If the next hour it is coming 250 ml, then that patient requires exploration. He is actively bleeding, he requires exploration. If it is 3 ml per kg, something around 150 200 ml for 3 to 4 hours consecutively, then also this patient requires exploration. These are the two conditions where you need to be intervened, doing something that the drain is more. Other than that, if let's see the serous fluid is coming or pneumothorax, that like the drain doesn't make, like you can't just generalize like this much will come. It may fluctuate like anything.
So one more thing is like in case, what would be the red flags that we have to identify in case if the patient has got, in the cardiac surgeries we do see, like patients will be having the more drains filled and we will be continuously emptying it very frequently.
No, that's what I have told. No, if in cardiac surgery they may have hemothorax, there will be they might be bleeding. Okay, if they are actively bleeding, your drain will be more. Okay, so if somebody is actively bleeding and the first hour drain is more than 250 ml, they require exploration, re-exploration. You have to open and see from where the patient is bleeding. That need to be taken care of. If let's say it is less than 250 or 300 ml in the first hour, but it is persistently 150 200 ml for the next 3 to 4 hours also, you need to open and re-explore. If it is less than that, you have to keep a close watch. In all this kind of situation, one more important thing what you need to look at are the vitals. Because somebody who is bleeding actively 250 200 ml per hour, their hemoglobin will drop. They may go into significant hypotension. These are the cases where we may need to replace your blood and maintain the hemodynamics. Sometimes blood, even they may require vasopressors also to maintain the blood pressure.
What might be the same kind of ml that which you are trying to mention in the pediatrics that we have to see?
Pediatric, what she has told, like 5 ml per kg in the first hour, and after that, if it is for 3, if it is less than that, if it is more than 3 ml per kg for 3 to 4 hours.
Those are the questions, sir. Thanks.
Thank you, sir, for sparing enough time. Audience also, like, they're very enthusiastic for more questions. We'll take your more questions. You can put us in the offline as well. We'll take Dr. Mishra's inputs before putting in the answers. Please log in to Yashoda Hospitals portal, Facebook, and thank you so much. Thank you, sir. And thank you, Hemabindu, for giving excellent presentation. Thank you.
Yeah, thank you, everyone.
Thank you, sir.